Perfect. Well, thank you for having me here to talk about this. I've done 2 cases so far, and I'll present those 2 cases. Um, in my practice is in Texas, McAllen. So the first case was a lady, 64-year-old, who presented with multiple myeloma. She had severe back pain and right hip flexor palsy secondary to compression of her unilateral nerve root at L1. She's unable to walk due to pain and weakness. We tried to brace and give her gabapentin, duloxetine, and optimize her care, but she continued to have pain and weakness, and her hip flexor on the right side was 0. A little bit more weakness in the legs, 4 out of 5 due to pain. A1C was 9.9. We did try to optimize that, did not work. And albumin, we gave her protein shakes for that. Her Hounsfield units in the CT scans in the thoracic and lumbar spine were both less than 100, showing osteoporosis. So this is her scan. In 2018, she did not have any problems at L1, and now she presents with this L1, right more than left, compressed vertebral body fracture with mild retropulsion without significant central stenosis with significant involvement of the right-sided pedicle on the CT scan. This is her PET scan, again showing L1 vertebral body lighting up along with some more increased uptake at L3 unilaterally and significant uptake at L5. And on axial upright images on Scully films, she had further compression of her vertebral body, right more than left, again causing scoliosis. This is an MRI with contrast, showing significant right-sided pedicular involvement with some epidural disease as well. And at bottom is an image showing nerve root compression, unilateral L1 nerve root compression. Dr. Gibbs and Dr. Chapman were talking about having scout films, and I was blessed to get this scout film, so I didn't have to worry about the other parts, at least cervical, spine, and brain. We did obtain a brain MRI, but it was nice to have this. So again, Dr. Gibbs already talked about SIN score. For this patient, SIN score was about 14, and it was unstable because this is a junctional level. She had mechanical back pain. This is mixed lesion, along with radiographic evidence of fracture with less than 50% vertebral body collapse and bilateral pedicular involvement right, greater, and left. Given these findings, I decided to do kyphoplasties at the levels below at L4 and 5. So we'll go through that again. Dr. Mendel already talked about this. Initially, when I began my practice, I did use kyphoplasty. Now I do vertebroplasty, especially because the balloon leaks with kyphoplasty. But again, bottom 2 levels were cement was placed about 8 cc's of cement at each level. I used markers and placed the screws. And Dr. Galgano talked about this. I did a midline sparing, unilateral pedicular access on the right side, entered and distracted. So you could see the 3 images where she had some right-sided coronal scoliosis that was corrected with a lamina spreader. And then we place some cement in that area and compress across it. This is intraoperative image. You could see again midline sparing. Left side is completely preserved. Right side, you could see the dura. I did a T cut and then a W cut, a pedicle to pedicle exposure, and you could see dura, and you could see some cement at the bottom, right about there. I use ultrasound to make sure that the cement did not come up into the dural space, and we don't have navigation, so this is the Chapman way of navigating and having things ready. So we use that. Here's a post-op CT scan, again showing bicortical screws, cement-augmented screws, non-fenestrated, so just put the cement in first and then chase it with the screw. Used cross connectors to share the load, and bottom 2 levels were, again, just cement augmented at the bottom 2 levels. She presented at 2 months with good complete resolution of her pain, significant improvement in her posture, no need for TLSO brace, and her hip flexor function improved significantly as well. I could not delete some of these findings, or at least the markings, but she was able to stand up straight, and that coronal scoliosis was completely resolved. So she's delighted with the outcome. It has really helped her, and she had improvement of hip flexor function to full 5 of 5. She began with 0. So that's the first case. Another gentleman, 68-year-old gentleman who presented 2 years after retirement, and he has good family support. His dad is in his 80s, and he's awake and around and walking independently. I like to ask my patients about what they did for work, family, etc., in terms of knowing the kind of support they're going to have if they're going to get big surgery. This gentleman unfortunately presented to me 3 months after starting to complain of progressive weakness and lower extremity anterior thigh pain. He wasn't able to ambulate for 2 weeks. He was in bed and family was feeding him, but they couldn't bring him in just yet. He was unable to sit up without pain, and even passive leg raise would cause him significant pain. Again, lower extremities were 1s and 2s. Upper extremities are 5 to 5. No Hoffman's, no clonus. He had a history of prostate cancer, so his CT scan, again, had Hounsfield units of 130s, no osteoporosis. A1C was 6.8, pre-albumin was a little bit lower, so which we fixed with protein shakes. Pre and post. This is a CT scan. The CT scan was done 3 months before his presentation. At that point, he already had stenosis and significant compression of his, just distal to his conus. Again, was lost to follow-up. Sometimes our scans don't get read for months, so he had the scan, but it wasn't read yet. He also had a PET scan done 2 weeks before as well. Again, the same thing. He had a significant L2 vertebral body disease, as well as right-sided SI joint disease as well, which you can see there. And it's significant lymphadenopathy, especially in the left supraclavicular region. Again, so this is his MRI with contrast showing bilateral pedicular involvement with significant compression of his cardiac vena and T1, post-contrast T1 and T2 images. And on the bottom, there's also the SI joint involvement right there and right here on the right side. Again, scout images as well. We get them, so this is nice that our MRI does that, and no other significant cord compression at this level. Given his SI joint disease and his L2 disease, I wanted to get your opinion on if this was a good case to go down all the way to the pelvis or just do a short segment construct, if you would do anything different.
What kind of diagnosis is it?
Prostate cancer. Would you go to pelvis?
For prostate, one above, one below. As I said earlier, is that L2? Sorry.
Yeah, L2. L2, yeah.
L2 is Jens Chapman speaking. For L2, I would do a posterior debridement, clean that very nicely, one above, one below. Consider if the bone quality is poor based on my preoperative Hounsfield unit assessment, percutaneous cement above and below, and then have the good Dr. Oskuian put a radiolucent peak cage into a far lateral approach because he's so good at that.
Okay. Yeah.
Large offloading cage.
Yeah, I agree. This is a great lateral case, the L2 level. At L3 as well, I think it's doable. At L4 and L5, obviously, you worry about the plexus and also not accessible at the L5 level. Hounsfield units, well into the 150s. I think there would be no contraindication to a shorter segment as opposed to needing to go longer.
Okay, perfect. Yeah, I ended up doing 2 above, 2 below. I ended up resecting both pedicles, and I did all posterior approach. So that's my approach there. And again, same techniques as initial distraction to get the cement in, and then posterior compression to keep that in. The images intraoperatively, again, was able to get the whole posterior elements out without any issues, given that bilateral pedicles were involved. This is pre-op. You could see the tumor in front of the spinal cord, or at least this cardiac vena starting here. And post-operatively, once the vertebral body was resected, you could see a big cavity where cement was placed. This is where I placed the cement. You could see the dura there, and cement was placed from bilaterally again. And these are his post-op images by cortical screw purchase with cement placement, reconstruction. And unfortunately, I lost him to follow-up, but I give my cell phone number to all the patients, so they text me. He's doing well. He's pleased with his surgery. They can't wait to show me him walking one day, so he's getting close to walking. He was in a wheelchair when I saw him last, but he's in a different city now, so it's hard to chase him down. Perfect. Well, thank you for having me. I really enjoyed my time here.
Thank you, Neel. Anybody has any questions?
So again, one more time, I want to hear from everybody, just because it's so important. Radiation permeability of PMMA compared to other biomaterials. How is it? This looks totally dense on this X-ray. What does XRT do when it hits PMMA?
Yeah, from the input I got from our radiation oncology, it's a non-issue with the PMMA. It's really the titanium that's the big evil. And that's why we're moving into these carbon fiber screws, carbon fiber cages. But in that sense, the radiation does not significantly affect the results. I would just say here, have you ever thought about just stick a needle into the vertebral body and inject cement into the body? Then you can fill up the whole body with cement versus putting it on top of the tumor, right there between the two discs. So one option is just to do a vertebroplasty at level once you got the
Right.
yeah.
Yeah, after you talked about it today, I'm definitely thinking about it because we don't have interventional radiology for embolization of our tumors. And so if I get a renal cell carcinoma, I'll probably try to do vertebral augmentation with cement to see if reduce bleeding before I go in. That's a really good idea. It's a really good idea.
And how much help do you have? I know, obviously coming out of fellowship where you have a nice team to do these cases. How have you found that down at McAllen, doing these corpectomy type of larger resections?
It's just I had my rep come up here and trained by you and Dr. Chapman, which was great. So he has all the tools, and we copied Dr. Chapman's set. So we have the set with the osteotomes and the pedicle markers, etc. Otherwise, I'm the supervising doctor in terms of anesthesia as well. We have CRNAs. I put the IJ in for these cases so that we have good control and A lines, etc. But yeah. It's sometimes that's all we have. So we don't have navigation. We have an X-ray tech and me. That's it. Yeah. So it's
nice
been
outcome.
Yeah. Thank you. That's why I couldn't have done this without being here. So thank you guys. Yeah.